Okay, so for spinal cord injury, I'm just going to go through, and if you have specific questions or want me to stop or elaborate something, just say so.
Okay.
All right, so we know that with the neurological system, there's two sources of input, right? So there's motor and sensory. Those are the two kind of hands of the neurological system. We have our brains and we have our arms, for example. So like in order to have a motor response, we first have the thought, I want to move my arm, right? And so that thought originates in the brain, goes down the neurons and the nerves into the hand, and that's what we call uh the efferent or exiting or descending. There's several words for it. You have the descending because it's coming down from the brain, or efferent, which means exiting pathway. So, and then you have the afferent or the ascending information. So, like if I were to touch a flame on my hand, that information is going to start at the hand and go up the nerve to the brain, right? So that's the ascending or the afferent pathway. So those two things make up the neurological system. You need both, right? Like if you had sensory without motor, you could feel everything, but you'd be paralyzed. If you had, motor without sensory, you could move, but you wouldn't be able to feel anything, which would be very dangerous, right? And that's a lot of like with diabetics, for example, they start losing like that sensory nerves, like especially in their feet, and they don't start to feel like when they step on anything sharp, so they get those wounds. So we can see
Mm-hmm.
that's an example of where like those nerves are starting to get decayed and it causes problems, right? So, anyways, that's the summary of how the neurological system works. You've got your spine itself is split up into four sections, and I had a little. I don't know if you can see it super well on the camera or not, but there's a. Can you see that pretty good?
Yeah, she actually gave us this picture, which is similar to what you
Oh,
have.
perfect. Okay, awesome. So you have something to look at.
Yeah.
Yeah, so the top of the spine, cervical, middle of the back, thoracic, lower, lumbar, sacral. And you have to know like um, how many vertebra and nerves are in each section. So the cervical has got 8, thoracic 12, lumbar 5, sacral 5. Do you have all that?
Yes. And then like what it controls as well.
Yeah. So this is I don't know if you mentioned this, a fun way to remember it is just breakfast, lunch, and dinner. Yeah, so
Mm-hmm.
8, 12, and 5, so you don't have to remember. Um, Knowing what they innervate is going to be important, and it seems like a lot to like kind of just memorize. Um, but it'll help you understand like what happens where depending where you get the injury, right? So let's say I got an injury at the cervical spine, everything below would be affected, right? So the lower the injury, the better, right? Because everything goes down. So if like I got an injury at C8, for example, everything thoracic, lumbar, sacral underneath is going to be like affected, right? So obviously having any type of a spinal cord injury is bad, but if you
Mm-hmm.
have to have one, you'd prefer it to be at like the sacral level because that's the lowest, and then everything above would still be fine, right? If you think of it like back to when I was talking about like it starts in the brain and goes down, right? If the
Mm-hmm.
spine is severed at a certain spot, right? The signal is not able to keep going. So like if this is the spine and it's severed, like it's not able to go farther than the break. So you lose everything below. So people that have, break their necks up here, it sucks because you lose literally everything. Um, what was the diaphragm is the one that is going to matter the most. C3, 4, and 5 is what controls the diaphragm. Um, you can remember it something like C through and 5 keeps the diaphragm alive, kind of
Oh,
like
that's
a handy little thing to remember. C3, 4, 5 keeps the diaphragm alive. And the reason why that matters is because if someone has an injury there, they're going to lose the ability to control their diaphragm, which means they can't make spontaneous breaths, right? So this type of person would have to be put on a ventilator to do the breathing for them, right? And that sucks because, you know, breathing is kind of, an important action of daily living.
No further explanation needed.
So obviously head and neck, that's simple enough with cervical, not hard to remember. The reason I bring up diaphragm is because it's just not intuitive. You think, oh, well, the diaphragm is down here, so you'd think it'd be like thoracic, but it's not. It's up in the cervical. So that's the I say the C3, 4, 5 keeps the diaphragm alive. Because that might be like a question like, asking about lungs and breathing with the cervical injuries. Thoracic is pretty straightforward. You have your chest, abdomen, and GI, which is all in your trunk area. So that's super intuitive. The GI part, there's kind of a lot to go off there though. If you think about everything in your abdomen, you've got all the organs, right? So you've got, your intestines, your colon, and everything. If you're not having motor or descending information reach the abdomen, what could potentially happen in your intestines?
An ileus?
Yeah. So, peristalsis is the cyclical movement of the, constricting of the intestine to shove the food out, right? And if they're not getting that neurological motor information, you could have ileus, impactions, that sort of thing. So that can be a problem. When we get to interventions, you'll see that like abdominal massage is a big one to try and kind of like produce that movement, trying to like get that stool moving. So GI is a big deal. What else? Let's see. With that GI, another complication, and we'll get to the complications in a second. I'm just kind of touching on them as we go. Another complication with GI being affected is with the stomach, right? So like, diabetics often have like decreased gastric motility.
Mm-hmm.
Yeah, so that'd be another thing that would happen with impaired, um, GI control, and because especially if there's an ileus, that stomach acid is still being produced, right? The stomach is still able to produce stomach acid, but it's just not like moving along, right? So it's just kind of sitting there, and you can get stomach ulcers. So that's another complication with the GI. Um, the lumbar innervates the legs, which obviously that would make sense, right? And then the sacral does the bowel, bladder, and sexual function. Um, so that's kind of sucks because like no matter where you have your spinal cord injury, your bowel and bladder is pretty much always going to be affected because it's the very bottom, right? So, and that's, people are going to have to be like intermittently straight cast or, have a Foley or something like that. Any questions about the locations?
No, they make sense.
I think if there's anything else. Oh, I mentioned C3, 4, and 5. The other one is T2 to T8. These innervate the intercostal muscles. So like the muscles like within the ribs. And
Mm-hmm.
I think that's important when it comes to like deep breathing, right? So like when you take a deep breath, like if you put your hands right on your ribs right here, take a deep breath, you can feel that those like your ribs expand, right, to make room for the air. So if you lose the innervation of those intercostal muscles, it's going to be really difficult to take deep breaths, right? So what would be a complication that you could think of related to not being able to take deep breaths?
Mm, I mean, they could get like respiratory acidosis.
Yeah. Specifically, I was thinking of like people get pneumonia, right? Because they're
Yeah.
not able to. A lot of people, if they're laying in the hospital, like they're not getting exercise and taking deep breaths, they're going to get pneumonia. So, like
Mhm.
the inability to take those deep breaths and kind of move that fluid around and stretch those lungs out, it creates an environment where pneumonia and fluid can build up. So, that's another potential complication.
Okay.
So let's just kind of talk about the complications since we've been doing that. Um, so we talked about a few of them. If someone has lost, most of their motor ability and are paralyzed, they're going to be, unable to move. They're going to be bedbound. What are some complications you can come up with off the top of your head?
Pressure sores.
Yep. So bed sores is definitely a big one, for two reasons. right? They've lost not just motor, but sensory, right?
Mm-hmm.
So if you sit in one spot for too long, like you can feel that like you need to move, right? Like, oh, my butt's getting sore, I need to shift, right? They can't feel it and they couldn't move even if they did, right? So they got to have like really good caregivers to like to know to keep them turned. And a lot of times like that doesn't happen, or like caregivers get burned out because it's like constant care, right?
Mm-hmm.
So bed sores definitely. What's another complication of not doing a lot of movement and exercise?
DVT for
Yeah,
sure.
DVT. Yep. They, especially in those legs, right? Because they're not able to move those. So, um, interventions for that.
Ted Hose, Lovenox.
Yep. SCDs. Same. We know what the interventions for DVTs are. We
Mm-hmm.
mentioned pneumonia, especially if they, lose those intercostal muscles, or if they lose the ability to control their diaphragm, right? They're just laying in one spot and they can't exercise those lungs. So we could tell the patient to have someone help them use an ICS, if at
Mm-hmm.
all possible. Um, what about with in relation to bowel and bladder loss? Can you think of any complications?
They could also get like skin breakdown from that.
True, yeah. Sitting in wet urine.
Mm-hmm.
Um, so like you and I, we're able to sense that our bladders are full, right? They would not be able to sense that. That we also have the ability to like voluntarily urinate because the control of that
Mm-hmm.
muscle, they cannot. So retention is a big problem, right? So like if their bladder gets full, like they can go, right? Like their body, like at some point, like you're not able to hold it anymore, your body will just go, which is why kids have accidents, but they may not have it all come out. So retention is a big problem, and retention leads to what?
UTI.
Yeah, because it's just a breeding ground for bacteria, right? Like that fluid, it's warm, it's wet, it's dark, which is like exactly the environment that bacteria like to grow. So UTIs are a big complication because of that, but also because these people are constantly having to get like invasive straight cath or like a Foley. And anytime you insert something, especially if the family member who's doing it doesn't really understand sterile technique, they're introducing something inside there. So UTIs are a big complication. Um, let's see, we mentioned ileus and compaction. We mentioned the stomach ulcers, um, bed sores. Um, Another one that surprised me was acute kidney injury. Can you think of maybe why an acute kidney injury would happen?
Hmm. We didn't talk about that at all.
Really?
Yeah,
Interesting.
I don't have it on my notes, but I'm not really quite sure.
Yeah,
Uh,
so if you can remember back to when you did renal, what were the three different causes of kidney injury? Do you remember?
medication.
Uh,
Mm.
Pre-renal,
Oh, intrarenal, and then the
post-renal.
recovery.
So there's pre-renal, which is like, everything before the kidney, so like maybe a heart problem or a blood pressure problem. Intrarenal is like, okay, something's wrong in the actual kidney itself, like glomerulonephritis or whatever. And then post-renal is like everything past the kidney, so like a bladder obstruction or a kidney stone or something.
I
So
do remember that.
so with this, again, with like the bladder being full, if the bladder's full, reflux can happen, right? So the urine starts backing up into the kidney itself and then causing a kidney injury. So urine is a big issue. Um, it's like a block. We talked about how like Foley's can cause a acute kidney injury if they get blocked and the urine's not able to come out and it backs up into the kidney. Remember that?
Mhm.
So this is like the same thing, like the bladder's not able to empty. So that could happen. Um, what else? Let's see. If you're not using your muscles and you're not using your bones, what's something that could possibly develop?
Osteoporosis
Yep.
and
So
like,
if you don't use it, you lose it, right?
mm-hmm,
So I don't know if you remember back from A&P, we've got osteoblasts and osteoclasts.
mm-hmm.
The osteoblasts are building up the bones when we exercise and we do weight bearing activity. The osteoblasts get activated. But when we're not, we're just laying around, the osteoclasts break down the bones and go unopposed. And so it's just constantly breaking it down, which is, bad for your bone density.
Yeah.
So, yeah. So something we can do for that is, we can give someone some bisphosphonates. Bisphosphonates are a medication that will kind of help decrease. I don't know if you remember from, I think it was in renal, we talked about the relationship of calcium to phosphorus.
Yes.
Like they're inversely proportionate. So it's like one gets higher, the other one goes down, right?
Mm-hmm.
So the bisphosphonates will help to decrease the phosphorus, which is damaging to the bones. So like there's a lot of phosphorus in soda, for example, and why they say that soda leads to like osteoporosis if you drink it a lot because the phosphorus is just and you need calcium for your bones. So if the phosphorus is high, your calcium's going to be low. So anyways, bisphosphonates will help to make your bones stronger.
Gotcha.
Basically is what that's saying. You can remember that bones need calcium, right?
Mm-hmm.
And if your phosphorus is high, then your calcium is going to be low. So we want to get rid of the phosphorus. So bisphosphonates will help get rid of that. So that's that's what that's for. Some other complications are contractures. You know what contractures are?
When it like gets stuck.
Yeah, so like you'll see like patients sometimes they'll have like their arms like really stuck like this and it's like super tight and it's like almost impossible to even like forcefully move their arms and stuff. This happens because as we're like actively moving and like living through life, we're like using our muscles and stretching them, right? So like you'll notice that like when you stretch a muscle, like you gain more mobility, right? So
Mm-hmm.
obviously like if someone's stretching to do the splits, like maybe they start out not being able to do it, but over time like their muscles stretch and are able to go down farther, right? So you gain more movement, right? So the opposite is true. Like as you don't use your muscles get less flexible. So instead of having like this full range of motion because your body is like being stretched and flexed every day, your muscles start to shorten because they're not being used and they're not being stretched. So instead of being able to like extend all the way, now maybe only extending here and then here and then here and then soon like the muscles shrink so bad that they're stuck in this position and like you can't move them because they're just so tight. So something, that's why passive range of motion for people that are paralyzed is really important to keep their muscles moving and used to like being stretched out. Otherwise, they're just going to keep shrinking until like all their muscles are like contracted like this, So
Mm-hmm.
that's again on the caregiver to do those things, and that's just a lot for someone to do.
Sure.
And the last complication I have is oh, sorry, I forgot to say something. So yeah, like I said, doing range of motion is helpful to prevent the contractures. Also, you'll see some people put on like splints, like to keep their arms straightened. Like so they'll have like a strap here and they'll have like a strap here with like something hard on the back to keep it like straight so that it'll like force it to stretch out rather than being able to kind of contract in. AFOs, I'm not sure what that stands for actually, but AFOs are like a special shoe. It's like they're like a little brace that you put on and it's like made of plastic and it like forces your foot to stay in a certain position so it doesn't allow it to like, you know, turn any other direction. It keeps it in the normal position. So you'll see a lot of patients with those to kind of help keep that contracting from happening. And the last one I have, let me know if there's anything on your notes that I missed, are sexual dysfunctions like erectile dysfunction, which obviously that makes sense.
Yeah.
And another one that was interesting that I wouldn't have thought of is, women that are paralyzed are still able to get pregnant, right?
Mm.
Like that doesn't stop working, right? So like if someone's married and they're paralyzed, they're still having an active sex life, they could get pregnant. But when you go into labor and delivery, you're asked to push, right?
Uh,
And you can't. So they would have to have C-sections. So yeah.
Interesting. We didn't talk about that. Um, we just talked about like obviously with sexual functions, like they would just be frustrated.
Yeah.
But we didn't have that under complications or anything. We have
Yeah.
respiratory, GI, cardiovascular, skin, musculoskeletal.
Yeah. I mean, there's tons that you could probably think of, but just if you think like, okay, well, if you lose sensory, what are some possible complications, right? If you lose motor, what are some possible complications? And just thinking like that. If you really understand that there's two like aspects of the nervous system, like the sensory and motor, like it helps make things make more sense. Um,
We
so
do
then also,
have, sorry, we do have baclofen under musculoskeletal for spasticity.
yeah, so that baclofen is a muscle relaxer, right? So that'll help prevent those contractures, right? Because it's causing the muscles to relax and
Mm,
loosen instead of like, get tight and from disuse. Because you know how like if you haven't stretched in a while, you feel tight?
yes.
Yeah, so like obviously if you're paralyzed, you can't stretch because you're not moving, so the muscles just get tight. But the baclofen will help to keep that from happening.
Gotcha.
Let's see. Um, Real quick, I don't know if I mentioned this or not, but like there's certain terms. So like if someone says they have a complete spinal cord injury, that means they've lost both sensory and motor, right? So when they say
Mhm.
complete, they mean both. If they say incomplete, obviously that means that they're able to retain some ability, and usually that's sensory. So like maybe someone may still be able to have some sensory input, but they won't have that motor ability. Um, I just didn't know if I had mentioned that or if that was in your notes.
It
Um,
is.
you said it is or it isn't?
It is.
It is, okay. And then the other thing with a spinal cord injury is, there's different types of spinal cord injuries. You could have like a complete separation, right? If someone's like, it just got completely severed. Obviously, that's not gonna like heal itself. But you could have like maybe a compression issue, like it got hit really hard, that nerve, and it's like just really damaged. And like, when something gets injured, there's a bunch of swelling, right? Like if you ever
Mhm.
sprained your ankle,
Yes.
and so like, all the swelling happens and now like you're not even able to move your ankle at all because all the swelling is there, right? So same thing can happen if you like twist or damage or tear your spinal cord. Like all that swelling is going to rush to the area, and that swelling puts more pressure like on the spinal cord, so it might look like they have a more severe injury than they actually do initially. So like if someone comes in with a spinal cord injury, you can't always tell right away like how bad it is, because sometimes it'll look like, oh man, they have a complete loss of everything, but it's really just like the fact that it's like an acute injury and it's a bunch of swelling, and over time like the swelling will go down, and as the swelling goes down, like sometimes they regain things. So a lot of times patients will be like, will I ever be able to walk again or whatever? And you'd be like, you have to tell them, like, we don't know. Like,
Mhm.
it takes time because the swelling has to go down. And sometimes it goes down fast, sometimes it goes down slow, sometimes like the swelling wasn't the issue and it really just is a complete tear. So it's kind of hard for patients not to have the answers. But that does also kind of give them some hope that it could get better, you know? One of the things that you can look for to see that they're starting to regain function is the anal wink. Did
Oh
you?
yeah.
Yeah. So if you think about it, like if you look at the little diagram of the spine and the cervical, thoracic, lumbar, sacral, and everything, and what the sacral is what innervates the bowel, right? And
Mhm.
that's the very, very bottom, right? So the anal wink shows that like it's starting to get better because it starts at the bottom and works its way up. So you can see like, okay, signs that this patient is getting better is, and the anal wink is like, how like the anus can like kind of flex a little bit, like you can you've I guess you have you ever seen a dog poop?
Yes.
So like their anus like kind of like, I don't know how you describe it, it just kind of like clenches,
Constricts.
yeah, constricts and
Yeah.
dilates. So if you start seeing that on a patient, like maybe when you're wiping them, maybe it'll respond to like the wipe and you'll see a little constriction. That's a good sign. That means that they're starting to regain a little bit, and it will move from bottom to top, right? So like you'll start at the very bottom and the anus is the very, very bottom and start to creep up. So that's always good. And when you see that sign, and that's probably going to be a test question because I remember the anal wink. um,
So I worked a lot in Erlanger's trauma bay this summer,
mhm.
and I saw a lot of doctors like roll the patient, like log rolled them on the side and then quickly like insert a gloved finger into their anus just to check and like ask them to clench their butt cheeks if they could.
Yeah.
Is that what that's checking?
Probably. I mean, like you can, it's also like the rectal stimulation helps too. Like, that's also going to be an intervention that you'll see come up later, like to help people like to be able to go, right? Because they won't be able to like constipation and compaction is an issue with them because like the decrease in peristalsis. But like when you do insert like a finger and do the rectal stimulation, it does help to kind of wake it up a little bit and help them to go. So they're probably doing that, but also seeing if they can get some of that return back because that's the first thing that would return would be that anal stimulation because it's the very very bottom of the spinal cord. People think, well, aren't the legs below the anus? And I'm like, well, yes, but like if you look at the spine, like the leg innervation is above, it's above the sacrum, and the branch of the nerve just goes down, right? So like the nerve connects to the spine above the sacrum. So I don't know if that's confusing to some people.
She talked about that in class today, and she showed us like the textbook picture of like it would be like S5 is like the lowest part.
Right.
And that's where you would see the anal wing, not L5, which is the bottom of the foot.
Right. Yeah. Okay, so that's that. So one of the things that they like to do is like if someone comes in and to kind of help get on top of that swelling, they want to give the patient methylprednisolone as soon as possible, like preferably within 8 hours to kind of really get on top of that swelling. Because like the swelling can cause further damage to the cord. Like as you have more and more swelling, it's more and more pressure, and like that pressure can like injure the spinal cord, right? So if like you can imagine if like there's a lot of pressure like on my hand and it doesn't let up, like eventually it might get necrotic and die, right? Like if someone's just like putting a lot of weight on it. So it's the same thing with like that spinal cord. You want to get a lot of that pressure off of it so it doesn't like get permanently ruined. So
For sure.
Steroids, methylprednisolone helps to reduce that swelling. So makes sense so far?
Yes.
So let's talk about some interventions. Um, and this, if you understand the complications, the interventions make sense. So interventions would be a Foley or straight cath. Why? Because, they've lost the bowel and bladder. Bladder scanning is a great thing to do just to make sure they're not having retention issues, right? So we're not developing like a UTI or any like reflux or anything like that. Possible ventilation support, like a ventilator if they need that, if they lose the diaphragm. Turning, coughing, deep breathing, and ICS, right, to hopefully stay on top of getting pneumonia because they're not able to, run around and get a workout, so get those lungs exercised. To decrease bed sores, we've got those wedges, those foam wedges in the hospital, turning every 2 hours. They even have like rotary beds that you just push a button and it like the bed does it itself. It will turn the patient itself. Or like we've seen like those air mattresses that like constantly are blowing like air in the mattress and it's like you've seen, I'm talking about?
Yeah.
So those are pretty cool. Those are fancy. TED hose, SCDs, obviously for DVT, also drugs for DVT. So, like you said, Lovenox or heparin or whatever. Drugs for stomach ulcer prevention, right? Because of that stomach acid. So, like, Protonics or something to, decrease, that GI prophylaxis. Pretty much everyone who goes in the hospital anyway gets GI prophylaxis, regardless of whether they're spinal cord injury or not. So, everyone gets Protonics, right? So another thing, maybe someone gets a C-collar or a back brace to keep them in position, right? Because you don't want to tweak it. You don't want to like roll them and have it get tweaked because it's already injured. Another thing would be like the halo traction. Did she talk about that?
She did.
Did she show you a picture?
She did. I made a joke because I was like, oh, it's the thing that like Regina George had.
Yeah. Yeah.
I didn't say it in class. I just said it to Red next to me.
Right. So the halo traction, helps to, especially with like compression. And I guess I forgot to talk about the different types that we'll go back to that. But like one of the ways that you can injure your spine is from compression. So like I don't know, if you fell on your head and like it compressed your spine, or someone like hit you with a baseball bat or something, I don't know. Like it helps to kind of like pull and straighten out your spine, like to pull it to, to keep it from getting compressed, and it will help do that. It also keeps your head very still, like you can't turn it this way or this way, like it's just stuck in one position. So what would be a very dangerous activity for someone to try to do if they're in a halo device?
Driving.
Yeah, so driving is not something they're allowed to do, because you're trying to drive and merge, you can't look over your shoulder, so no driving for them.
So
Another thing for them is the pin care, right? So like they have like the pins from the halo device like into their head, so that's a possible source of infection, right? And that's not like those tractions that are like on the legs, like
yeah.
external fixations, like we care about infection with that, but that's like in the leg, right? We're talking about something going into the skull, so that's like a lot more risky. So like no swimming, right? I don't know how you would swim with your head stuck like this anyways, but we don't want anything nasty to get in there, because that goes straight to the brain. Another intervention would be like chest physiotherapy. Have you seen like those chest vests that some people have, and it like has air that like forcefully goes in, it like shakes their lungs, like it's like a fancy vest they put on, and it's attached to like a machine, and it like really just shakes their chest a lot to kind of break up any fluid that's in there.
We
They
just
call it,
learned in
huh?
P.
Yeah, it's called a CPT vest, or a chest physiotherapy. A
Mm-hmm.
lot of people in home health like have that, and I do a lot of home health. Um, some other
Is
things
Halo
would be like,
traction,
huh?
sorry if I'm breaking up a lot. Is Halo traction used just for like cervical spine injuries?
I would think so, because it's not going to
Or
do much
neck?
for anything else.
Yeah.
Like it's not
Okay.
going to really have much impact on like lumbar or
Yeah.
thoracic. So I would assume it would be just like a cervical compression or something like that.
Okay.
Um, if someone's they might be a candidate for getting the flu or pneumonia vaccine to help just to kind of prevent that. Um, they might need some TPN while their bowels are, working themselves out. Um,
Mm-hmm.
Another intervention, especially for the bowel, is like getting in a regiment routine, right? So the bowels do better with like having a routine, because it just makes it easier to go. So like they'll try to like get you to poop like at the same time every day, to help kind of have your body like be ready for it, because they're not able to just kind of like the peristalsis just isn't great and all that. Having a lot of fiber to prevent constipation. So like Metamucil, to just really keep it from getting dry, because constipation is a real problem. Or like I said, the rectal stimulation and the abdominal massage to try to help keep those bowels moving. So, any questions about those interventions?
No.
Cool. Okay, so let's talk about um
Can we talk about the differences of like spinal shock, neurogenic shock,
yeah.
and then the autonomic stuff?
Yep, that's where I'm going to next.
Sweet.
So let's start with spinal shock. Um So this one is where the patient has a complete loss, so it's both sensory and motor, right? But it's temporary. So like they're not having like a complete break, like a complete severing, right? They're just having a shock. So whether it's, from like compression or swelling or something, so like it's not permanent. It's temporary, but they're having a complete loss at the moment. So you can imagine what kind of signs and symptoms they would have if you don't have um any motor or sensory. They're going to have flaccid paralysis, right? So they're just going to be like a rag doll, just limp, right? They're going to have very little sensation anywhere, right? Because they have the complete sensory block. They're not going to even have any deep tendon reflexes. So you know how like when you go to the doctor and they take the little hammer and they like bang your knees, right?
Yes.
You're not going to have those, because they're not sensing it, right? And even if they did, they couldn't respond. So like why we do the deep tendon reflexes is to test the neurological system, right? Because it gives the sensory input and it measures how fast like that sensory input is able to travel up to the brain and then for the brain to send a signal back down to have a motor response. And usually it's very fast, right? So that shows like how fast like the nervous system works. Like it happens like instantaneously for it to travel up and then travel all the way down, but they're not going to have deep tendon reflexes. They're also going to have loss of bowel and bladder. And that's, you'll start to see that return of the anal wink, which will signify the recovery, right? So the only difference is that it's just not permanent. So you'll have very similar interventions for these people, right, while they're in this condition that we just talked about, because they're still at risk for all the same things,
Yes.
So I think that's pretty much it for that one. Do you have any questions about the spinal shock?
Let me see. No, not really. She just told us like exactly what you said. I mean, it's immediate. It's below the level of injury.
Yeah. So obviously you're not going to be affected above where the injury is.
Yeah.
Because the brain is still able to send a signal there. So yeah.
Then
So this one's just temporary because it's caused by edema and swelling. So the difficult ones are the neurogenic and the autonomic dysreflexia. So let's spend time talking about those two because when I was in school, I was very confused by those two, and I was like, I don't understand. so so I'll start with neurogenic shock first. Okay. So neurogenic shock, this is where, okay, before, let me back up. You do remember in A&P how you have you have your central nervous system, right? And that's talking about your brain. Then you have your peripheral nervous system, which is like everything below, right? So like your arms and legs, whatever. So within your central nervous system, you have two branches. You have the you have the sympathetic nervous system and you have the parasympathetic nervous system. Remember, sympathetic was like fight or flight, right? So they're preparing you for action, right? Like heart rate goes up, blood pressure goes up, you're ready to fight or flight, you're ready for a threat, right? The parasympathetic nervous system is the opposite. It's I'm resting, I'm calm, I'm focusing on digesting right now. So fight or flight and rest and digest, right?
Yes.
So those are the two options. Now, normally in like a normal person, those two are like working together to create like a happy equilibrium, right? So like right now, mine are working together to keep me like awake and alert and functioning. I'm not like so tired that I have to go to take a nap, but I'm not like so high strung that like my heart rate is crazy and I'm like so nervous I can't focus, because they're working together, right? Now in neurogenic shock, you lose your sympathetic nervous system, right? So your sympathetic nervous system is just gone. Like it's just not working, right? But your parasympathetic nervous system is still working. So that just means that your parasympathetic nervous system is still being fired unopposed. So the sympathetic nervous system can't counterbalance it and even it out, right? So what's going to happen is you're going to see like the rest and digest like off the chart because there is no sympathetic nervous system to counteract it, right? So you think vital signs. What's that going to look like? Heart rate's going to be super low, right? Bradycardia. You're going to see, very low blood pressure, because they're vasodilated, because there's no threat. We're just worrying about resting and relaxing and digesting, right? Does that make sense?
Yes.
Vasodilation, which is going to cause low blood pressure, bradycardia. Your skin is going to be warm and dry, because of all that dilation, right? So your skin's going to be warm. You're going to have poor perfusion though, because your blood pressure is so low and your cardiac output is going to be decreased, right? And so like this is a problem because like most people aren't like Olympic athletes that their heart is so strong that they can survive off of like 40 beats per minute, right? Like most people need more than that, right? Like to survive. Like you can't just have reduced perfusion to all your internal organs and like live. So maybe if you were Lance Armstrong, it would be fine. But, so we need to fix that, right? So we need to like intervene some way so that they're not like dying from having no blood flow to anything. So some interventions. what kind of interventions can you think of to increase that blood pressure?
Vasopressors.
And what else? What do we give?
Fluid.
Yeah. So fluid and vasopressors are going to be the big ones. Now, do you think it matters which order you do that in?
Um, Probably fluids first.
Yes. So if someone's got really low blood pressure, right, you want to give fluids first and then vasopressors. Reason being is because if you give vasopressors first and now like their arteries are like constricted and tighter, it's much harder to push fluids in, right?
Hmm.
It's much easier to push fluids in when everything is loose and low pressure, right? It's much easier to take something and put it into a low pressure environment than it is to try and force something into something that's already high pressure. So I forget, I made up a little thing. I can't remember what it was. It was like uh something about fill the pump before you, I don't know. Never mind. Just remember fluids before pressors. I can't remember what I tried to come up with, but does that make sense though? Like
Yes.
harder to get fluids in if you give pressors first. So
Hmm.
pressors, would be like dopamine, dobutamine to get that heart to pump and whatnot. Um some other interventions would be like some compressions for in those legs, right, to kind of squeeze any fluid and blood from the periphery into like the central blood flow because we need it there, right, for the internal organs. um might give some atropine for the heart rate. um they might need a pacemaker temporarily to keep it going because, right, because the brain is just telling it to slow down. So you got to get a pacemaker to be like, nope, we're speeding up, thanks, right? um and then body temperature management is just going to be important, making sure they're not getting too cold or too hot or anything. But that's neurogenic shock. Does that make sense?
Yes.
I think there's anything else on here that I missed.
Let me see. She made us write out this whole like chart today, kind of.
What chart?
Uh, it's like not. It's something she wrote on the board that we just like copied. So I wrote it like
What was it
it,
about?
it was just like comparing all three of them.
Oh, okay. Yeah.
Um, and then she told us like obviously the parasympathetic goes along with the vagal system,
Hmm.
so that's why they would have the bradycardia. But that was it, and that it's T6 and above is injured, so it would be below the nipple line.
Yeah.
But other than that, nah, you said everything.
Yeah. So if you just think about like how you've got the sympathetic and the parasympathetic, and the parasympathetic just goes out of control because it doesn't have anything to oppose it, then it makes sense. Like you can expect what the vital signs are going to look like, and you can expect what you can do to fix it, right?
Yes.
Now with autonomic dysreflexia, the key word here is like the dysreflexia. Like if something is dys means like it's not working well, like if something is dysregulated, right? That means it's not working. So like in the autonomic part is referring again to the autonomic nervous system, right? So like I don't go, I'd really like to speed up my heart rate right now, and then my heart like listens. Like that's not under my voluntary control. So that's under the autonomic system, right? So you have the what is it? The autonomic and the what is it? What's the other one? It's not voluntary. I know that's not the word, but oh shoot. This is gonna bother me. But you
We
know what I'm
can
talking about.
Google.
You have the autonomic nervous system and the one that refers to like everything that's voluntary and that you actively control. Like I'm telling my arm to move, but I can't tell my heart to beat faster,
It's
right?
somatic.
Is that what it is?
It says that's what Google says it is.
Okay. I just can't. AMP was a while ago. Okay, that was
Yeah.
like back
It's the
in 2014.
autonomic versus somatic.
Sonomic,
Somatic.
somatic. Okay, whatever.
Somatic.
Sure, we'll go with it. So, like I was saying, the sympathetic nervous system and the parasympathetic nervous system are branches of the autonomic nervous system, right? Because I can't control any of that. That's not up to me. So it's automatic. So what they're saying here is that within the autonomic nervous system, there's dysregulation happening, right? So they're confused. So you still have the SNS and you still have the PNS, whereas like in the neurogenic, you lost the SNS completely, right? So with the autonomic dysreflexia, you still have them, but they're just not communicating well. And there's some kind of disagreement and they're not making sense. Does that make sense?
Yes.
So they're just not working together very well. And like you have conflicting signs happening all at the same time. So what happens to trigger this is that you have some sort of trigger that starts this whole process. So I'm sure she talked about in class how like something happens to trigger the sympathetic nervous system, and then this whole like rest of the stuff happens. So like maybe with them they have a full bladder, right? And that feeling, you know how like when you're full, like a full bladder is like really uncomfortable, and then it's like, oh, I hate that feeling, right? That feeling can trigger the sympathetic nervous system, right? Because it perceives it as a pain or as a threat, right? So like, have you ever noticed that like you're playing sports or something and you get injured, like you have that adrenaline kicking in? So it's like that fight or flight starts taking over. Or maybe like they're in pain or something, so it triggers the SNS, or maybe it's too noisy in the room or there's a lot of stimulation happening and it triggers that sympathetic nervous system. And it causes this whole weird thing. So what happens is like below the level of injury, like let's say I have a C8 injury or whatever, the sympathetic nervous system is going to get activated below the injury, and the parasympathetic is going to get activated above the injury. So you're going to see weird, like vital signs happening, right? So maybe the blood pressure is super high, but the heart rate is super low, and you're like, okay, that doesn't make any sense, right? So if you see conflicting vital signs, then you know it's the two autonomic nervous systems like not communicating well. Versus where if they all are the same, they're all like low, that's going to be the neurogenic shock where it's all the parasympathetic nervous system.
So you said the parasympathetic nervous system would be working above the injury
Yes.
while the sympathetic works below.
Yes.
Okay, having the conflicting vital signs. Okay, that makes so much more sense.
Yeah.
I
So
get
like for example, if I had an injury at like, C8 or whatever, I'm going to have constriction below that injury, right? So like I'll have, my vessels will be very constricted below, but then like above will be extremely dilated, right?
it.
So like up here is going to be very dilated, which some things that you would see would be like maybe I have a really bad headache, right? And that's because all the blood is rushing to my head, right? I'm going to have really bad like nasal congestion because like the vessels in my nose are super dilated and there's a bunch of fluid, and edema there. It feels like I just can't breathe through my nose, like nasal congestion. What else? You'll have like facial flushing, right? So like their cheeks will be red because again, all the dilation, the blood rushing to the cheeks, to the face. So they'll have like all that happening above the injury, and then below it's going to be the opposite. So if there's constriction happening below, their skin below the injury is going to be like cold instead of hot, right? Because the lack of blood flow is going to be like creating a cold skin, whereas the facial flushing is going to be warm. Does that make sense?
Yes.
What else?
The bradycardia would be because of the sympathetic nervous system
Yeah,
or the parasympathetic.
the parasympathetic nervous system is going to affect the heart, and then the sympathetic nervous system is going to affect the blood pressure. And it's usually like if you think about like if someone's in pain, right? Like your blood pressure goes up, right? So like when you do vital signs on someone who's normal, right, and they're in pain, their blood pressure is going to be high, right? Not because their heart is something's wrong with it, but just because that's what happens. So like if something painful or something stimulating triggered this to start with, it makes sense that their blood pressure would be high. So just look for those conflicting vital signs. So like if obviously like on your test, the test isn't going to be like your patient has autonomic dysreflexia. What are you going to do? Like that's not how the question goes, right? The question's going to be like, patient comes in from the ER with motor vehicle accident affecting C8. Signs and symptoms are facial flushing and bradycardia with high blood pressure, and you have to be able to figure out that that's what it is. right?
Mm-hmm.
So just looking for those cues, like if there's disagreement, it's autonomic dysreflexia. If it all agrees and it's all low, it's going to be the neurogenic shock.
Got it.
Does that kind of help a little bit?
Yes, it helps a lot more.
Now, if you have a lot of dilation happening in that head and you have like a lot of blood flowing to that area, what could that possibly put you at risk for?
Um, Increased ICP,
Yeah, and what can that lead to?
hemorrhage.
Right. So you could potentially have a hemorrhagic stroke, right,
Mm-hmm.
from all that blood like rushing to the area. So with patient positioning, do you think it'd be a good idea to lay them flat or to have them sit up?
Have them sit up.
Yeah. So gravity will help not have that happen so much. If they're laying flat, blood's just going to go whoo, right? So have
Yeah.
the patient sit up. It'll at least help drain some of that out is a little bit. Um, so some interventions, sit the patient up, identify and remove the stimulus that's causing this, right? So like when I remember when I was in class, years ago, she was like, anything can be a stimulus, right? So like bladder scan, check and see if that bladder is full. Even like super wrinkly sheets that they're laying on could be causing this, right? So this all happens when something is triggering the sympathetic nervous system, and then like it just because the nerves are all confused because they're damaged and whatnot, they just don't communicate well. So then the parasympathetic gets activated to try and like as a compensatory mechanism to try and counteract that sympathetic response, but they can't communicate because there's that severed bridge, that nerve or whatever has been severed, so it can't cross the bridge, so the communication's getting diverted, and it's just having all this weird stuff happen. I'm sure there's a more like fancied explanation, but I'm not a neurologist, so
Okay. That's the job.
yeah. Yeah, so someone is if someone's having one of these episodes, trying to find the stimulus and removing it will help to have everything calm back down, right? Because that
Yeah.
it'll stop having the sympathetic nervous system getting fired, and then the parasympathetic nervous system won't feel like it has to rise up to compensate, right? So you have both of them rising up to compensate in different parts of the body because they can't cross the bridge, if that makes sense.
Yes.
Um, if their blood pressure, gets super, super high, you can give them like hydralazine or, nitro to help bring that down. Um, the main goal here is just to prevent these episodes from occurring, so being able to like anticipate, um, like, hey, maybe don't have noisy visitors come in. Maybe let's make sure their bed sheets are like comfortable. Let's make sure to keep them bladder scanned, um, bowel regiments, you know what I mean? So
Mm-hmm.
those are the kind of interventions that you want to focus on. Um, yeah, what else? Let's see if there's anything else I have on here. Um, Typically, autonomic dysreflexia happens when you have a higher up spinal cord injury. So usually at T6 or above. So you probably won't see it if they have like a lumbar injury, or sacral injury, usually T6 and above for whatever reason. Um, yeah, I mean that's pretty much it. Did that help make sense of the three of those?
Yes, it helped a lot more.
Yeah, I know it can be like a lot. The first time I read this, I was just like, I don't understand.
I
But
was confused, but now I'm a little bit more clear. I just gonna keep working through it and talking about it.
cool. Let me see what else is there. I think that's it for spinal cord injury. Um,
Yeah, that was all we were able to get through. We didn't finish it all yet.
where'd
We
you
still
end
have,
off?
we ended at autonomic dysreflexia interventions, table 37.8. So we
Okay.
just have like a page and not even a half left.
Yeah, so I mean, a lot of this interventions are just getting rid of a stimulus, right?
Mm-hmm.
And the same things you would do with any spinal cord injury. So we're still, you know, doing bladder, straight caths, we're still doing bowel routines, we're still like doing all the things we mentioned before. Um, but just an emphasis on
Can you
trying to.
explain?
Mhm.
Sorry. Can you
You're good.
explain how like wrinkly sheets could cause that?
I mean, if you just think about like if you're laying in bed and you're just like laying on top like a wadded up blanket, that's going to be irritating after a while, right? It's just they're just more like they're in a heightened state of so like even small things can trigger them into this system. So, these people definitely need things to be very calm and quiet to prevent their SNS from getting stimulated, right? Because their nerves are just going haywire. So something that wouldn't be as stimulating to us would be more stimulating to them. She just mentioned wrinkly sheets because just to emphasize the fact that like even something small could be like sending a triggering stimulus. So like just make sure like they're not laying on a bunch of wadded up sheets because you know how like some people in the hospital like their beds get crazy and it's like they're just laying on wadded up blankets. It's like just make sure the sheet is on right and the blankets are not like wadded up underneath them just to keep them like in as comfortable, quiet, and calm as you can to prevent them from going into this autonomic dysreflexia like situation. So
She had mentioned it today too, like the wrinkly sheets. So I just wanted to ask about it.
mm-hmm.
But I actually gotta go, but I appreciate you.
Oh, you're good. That was all I had anyways. We'll do traumatic brain injury and like stroke in the next couple sessions. So
Perfect. Yeah. I'll be here.
all right. Bye.
Bye.